Hello, everyone, and welcome to the third session of the Building Your Defense Expert Speaker Series brought to you by Brownlee LLP in partnership with Viewpoint Medical, Investa Forensics, and Westbridge Ventures. My name is Nabil Pierre Mohammed. I'm a partner in the Insurance Defense Group at Brownlee LLP, and with me is Senior Associate Michael Thorne. We are your hosts for this speaker series.
The purpose of this series is to emphasize the benefits of proactively responding to personal injury claims by beginning to build a defense as soon as the first notice of loss is received. To do that, we've invited medical, mechanical, and investigative specialists to speak about their expertise and the ways in which they can help us bolster our positions. Notably, all of the medical experts, including Dr. Acharya, who's here with us today, contributed to our victory in the armbruster and nutting trial that took place last November, where the claimant was awarded nothing for past or future loss of income and had his overall claim slashed by 40%. Throughout today's session, we will address questions posed in the chat, so feel free to get those up whenever they come to mind. And at the end of the session, we'll be sure to email everybody to ensure that they receive their CIP credits.
Dr. Acharya holds the position of medical lead of the Orthopaedic Rehabilitation Program and the Burn Rehabilitation Program at the Glenrose Rehabilitation Hospital. Additionally, he is the medical director of Physiologix Medical Ltd, a large electrodiagnostic laboratory and multi-specialist neuro-musculoskeletal care outpatient clinic. Dr. Acharya, thank you so much for joining us today.
Oh, thanks so much for having me. It's my pleasure.
Dr. Acharya, we'll start off with the softballs and maybe just begin by asking you to please tell us a little bit about your professional background and what led you into physiatry.
Okay, sure. Well, that goes back a long ways because I've been in practice now for about 12 years and residency before that was 5 years. So really I guess, decision making to try to become a physiatrist happened, I can't believe it, but almost 17 or 18 years ago now. So at the time I was really interested in neurology as a medical student. And then a friend of mine who happened to be co-trained as a nurse and a physical therapist was working at the Glenrose Rehab Hospital, where I now work. For part of my practice, and she said, "Oh, if you're interested in neurology, you ought to check out physiatry because it's a pretty cool mix of neurology and some other stuff." And so, kind of on a whim, I just checked it out because at that time physiatry was not very well known. So there's maybe I want to say a dozen physiatrists in Edmonton, and since that time it's grown a lot. There's I think something like 40 physiatrists in Edmonton now, or something like
that.
Wow. Doing various different things. So the field has really boomed and become well known. But anyway, I had a great experience in my first few interactions with physiatrists and seeing the types of patients that they see and the way that they think. And I to be honest with you, I almost immediately fell in love with it, and pretty much begged my way into the residency program at that time, and was fortunate enough to get a spot in there. It's crazy these days the caliber of people that are applying for these residency positions is just, I mean, if you're not like a Michelin star chef and an Olympic athlete and all that, your chances are low. Yeah. So fortunately for me, I squeaked in before that happened. And so
much like me with my law school application.
Yeah, us too.
It's just getting wild, right?
Yeah. Well, you know what? That's a great segue then into my next question, which is, could you tell everybody a little bit about what physiatry involves? Bearing in mind that your audience is not I'm going to go out on a limb and say there aren't many folks that are on this call that are medical specialists. So could you just tell us a little bit about physiatry?
Sure. Maybe just so I can tailor it properly. Who is the audience again? It's
we've got a number of different folks across the insurance sector, primarily be claims handlers, examiners who are familiar with going through medical records, but don't have any formal medical training.
Right. Okay. Gotcha. Okay. Yeah. So physiatry goes by two names. One is physiatry, and the other is physical medicine and rehabilitation. And basically, we focus on the musculoskeletal and neurological systems in terms of diagnosing the problems when people present with symptoms in those that could be attributed to those systems. So diagnosis and then investigation of those symptoms, management of those symptoms, whether that's through medications or planning rehabilitation plan, like multidisciplinary rehabilitation plans with physical therapy, occupational therapy, psychology, speech language pathology, et cetera, recreation therapy, large teams depending on the setting a person's working in. And so we typically coordinate those rehab plans. And then we are expected to be able to, rationally talk about prognosis with a patient, and then balance all the patient factors that come in on that, and come to an agreement overall on how a person's rehabilitation should look for their various musculoskeletal and neurological problems. So that includes the big area, that includes big things like brain injury rehabilitation and diagnosis, stroke rehabilitation and diagnosis, spinal cord injury, peripheral nerve problems, spinal canal problems like the bones of the spine, the other bones in the body, whether they're fractured or degenerated or have some kind of congenital abnormality with them, all the way down to the muscles, ligaments, and tendons.
Right. Right.
So you could say it's pretty much dealing with everything outside of the internal organs. So we've joked before that it's not internal medicine, it's external medicine.
Yeah.
It's basically the orthopedic system minus surgery, and and we deal with the rheumatological system, meaning the bones and joints, except that we typically don't get involved in prescribing high-level immune modulating medications. That's typically in the realm of rheumatology. So it's a field that has a lot of overlap with other fields, including neurology, rheumatology, orthopedics, and even neurosurgery, and to some degree plastic surgery as well.
Okay.
Yeah, so it's a very broad field. And so what that means is that different physiatrists practice in different ways. So there's a variety of ways of categorizing physiatrists. So things you can look for. Generally, there's so many different ways of categorizing it, but I'll go through the main ones that I see. So one is inpatient physiatry versus outpatient physiatry or community-based physiatry. So in inpatient physiatry, we're usually dealing with people that, like the patients have come through the acute care hospital system because of one of those types of problems I was describing earlier. And they're in a subacute phase where they're medically stable, but starting their rehabilitation process. And those people are usually not at a state where they're ready to get home yet. So they require a high level rehabilitation care where they're accessing large rehabilitation teams for several hours a day. That's one type of physiatry practice. The other is community-based practice, where we're seeing patients on what's called an ambulatory basis, meaning patients are they're not living in a hospital. They're usually living at home or in some other dwelling, but not in a hospital.
Yeah.
And we're seeing them for their ongoing musculoskeletal or neurological problems. And then in that, like further dividing that realm of community physiatry, there's acute physiatry and then chronic physiatry. So there are some physiatrists who will see problems like, say, concussions, broken bones, sprain and strain injuries, acute sports injuries, stuff like that's just happened. And they may be the main physician that's involved after the person goes to an emergency room. And then there's people that deal with mostly just the chronic type of problems, where people have had these problems for months or years, and are looking to reduce their symptomatology or become more engaged in their life, etc. So there's lots of different potential physiatry practices. And then just a couple more things on that. Some physiatrists have subspecializations in various areas. The most typical would be to perform nerve conduction studies and electromyography, which is a way of looking at the peripheral nervous system. So when people have complaints of numbness, tingling, weakness, instability, that kind of thing, there's electrical tests that can objectively document nerve damage and recovery and stuff like that. Excuse me. And then another specialization, which seems to be the main thing that a lot of people are doing these days, is injection-based treatments, what you call interventional management. So they learn how to use an X-ray machine or an ultrasound machine to guide a needle to a specific muscle target, and then inject something or the other in there.
Okay. And then just since we're on the subject and before we get too far away from it, we've heard a little bit about you, and then now you've given us this explanation of the different types of silos, so to speak, that physiatrists can find themselves in. And so then just for everybody listening, in case they're thinking to themselves, well, when would I turn to Dr. Acharya and engage him? So which of those, of the contexts that you've just described, should everybody understand you to primarily focus in?
Okay. So my practice is quite diverse. Basically, of what I mentioned there, the only thing I don't do is I don't do interventional management. So I don't put the needle in the person, but I do generally. But I do, select which patient should have which procedure, and I interpret the outcome, like the results and the outcomes of diagnostic interventions and treatment interventions and stuff like that. But I just don't actually put the needle in the person.
Right.
So what I do, on the other hand, to put it in in that way. Well, maybe I'll just do it the way I've explained it for the courts before, when they sometimes ask like what I do. So I just usually walk them through my general week. So basically, it's like this: Monday, Wednesday, Fridays. I'm in my private practice, which Nabil you mentioned is called Physiologix, and there I have a general physiatry practice where I see acute problems coming directly from the emergency room, chronic problems coming from family medicine practitioners or from other specialists like orthopedic surgeons and neurologists and stuff like that. A lot of that part of it is chronic pain management, and a lot of the acute stuff is actually concussion and fractures, and acute whiplash injuries actually. And then and then electrodiagnostic medicine, where I'm doing the nerve testing. That's typically my Monday, Wednesday, Friday. Typically, my Tuesday, Thursday spent at the Glenrose Hospital, where I have a clinical role as the physiatrist in the orthopedic and burn rehab programs. So there I'm working with these large interdisciplinary teams, dealing with people that have had substantial injuries, bad enough that they're in hospital for generally months at a time, and are generally not getting back to normal. So I see that population. And then, right, and then I also have that administrative role at the Glenrose that Nabil you were talking about earlier, where I function as the medical lead for the orthopedic and burn rehab programs. So
Right.
I think I like to think of myself as well positioned in this whole thing because I see people that get better. I see the natural history of like most of the acute problems, which is that they should get better. And I also see when people are not getting better, I see the complexity of what happens to the people that don't actually get better. Um, like it's usually that they've broken multiple bones, had multiple different neurological injuries, and that's what's stopping them from recovering. So, um, yeah, sometimes I find that like I'm often asked to provide critiques, I guess, or responsive opinions for other physiatrist reports, and I see that the siloing has an effect. Like when someone's siloed into only doing interventional pain management, for example, only seeing chronic pain, they have a certain way of thinking, which I think is limited,
Right.
and don't necessarily see the big picture. So I would say, I think the question was something like, "What do you do?" and also, "When should someone think about, sending someone my way for an
Yeah.
assessment?" I think basically, and so I would say if there's a question of whether there or not there was a whiplash kind of injury, whether or not there was something more than a whiplash injury, to explain ongoing symptoms, whether or not there was a brain injury actually sustained or not. These are common questions that I'm asked, and I haven't approached all those, which we can certainly talk about. And then I would say if people have been diagnosed with injuries, but they're at a time point which is beyond the natural history of healing for those injuries, but they're still having symptoms,
Right.
um, I think I'm well positioned to comment on those situations there.
Yeah, very good. And the two things that stand out to me the most, and we'll move right along here, but the two things that stand out to me the most are the brain injury aspect of it, and then if people
Yep.
have symptoms that are persistent beyond the time period we would expect them to resolve. And that's the
Yes.
two things that Nabil and I are seeing most frequently. I'd say the whole team is
Okay.
several months after the fact, people started to report that maybe they lost consciousness or maybe they did actually hit
Right.
their head, and so it raises that question of was there, right?
Mhm.
And then we need someone like you to step in and take a look at, well, what was the reporting like during the immediate aftermath of the collision? But then the
Yeah,
other
yeah,
thing we're
right.
often contending with are, seemingly minor soft tissue injuries with symptoms that persist beyond, 6 to 8 months. 3 years later, they're still reporting issues.
Well, exactly. So one of the main, can I just jump in there? Is that okay?
Absolutely.
Okay, but one of the things I see there, so commonly, it's actually almost to a point where it's frustrating, is that people will diagnose a concussion on the basis of what they're referring to as post-concussive symptoms. So hopefully the audience is somewhat familiar with that, but it's things like vague complaints of dizziness or vague cognitive problems that are fluctuating, for example, vague language problems like word finding, people complaining of word finding abnormalities, vague complaints of attention and concentration difficulties and stuff like that. So those sometimes are interpreted as post-concussion. My take on that is that it might be post-concussion symptoms, but there's a differential diagnosis to be considered there. And if you're going to put post-concussion onto that differential diagnosis, then there must have been a concussion in the first place. And what I see is that people often use subjective symptom reporting after the fact and say things like, well, this fulfills the XYZ criteria. There's so many different criteria for concussion diagnosis. This fulfills the criteria. And what I say is, yeah, that puts it on the differential diagnosis that a concussion may have occurred. sorry, I'm just jumping around a little bit. What I'm trying to say really in a nutshell is that there are acute symptoms that could be a concussion, but there's a differential diagnosis that should be explored. And we can talk about that in just a second. And then there's also chronic post-concussive symptomatology that, again, may be a post-concussion symptomatology, but a differential diagnosis must be explored. Like that's the medical methodology, is that you come up with a differential diagnosis and then justify why the diagnosis that you're settling on is in fact the diagnosis.
Right.
I see that step just being skipped, it seems like, or I don't know, glossed over, and like I don't exactly know how to explain it because nobody's that poorly trained. So
Well, on that note, I think I think it was you and I that had this discussion, but isn't the and if it wasn't, please excuse me, but isn't it the case that oftentimes and this is I think a good takeaway for the folks that are listening, depending on where we go with this, but isn't it the case that most of the time treating physicians are more concerned with simply addressing symptomology than getting the correct diagnosis? And so if you have someone that comes to you 3 months after a collision and they say they've got headaches and neck pain and a little bit of nausea and they might have hit their head, the person they're reporting that to is going to be more concerned with just treating their symptoms than going back, getting the records from, the emergency records, or considering what the paramedics had to say when they looked at them on scene and getting the proper diagnosis. They're less concerned with that than they are just saying, all right, well, it might be a concussion, but let's focus on your symptoms. So might that be an explanation that they're less concerned with proper diagnosis and more concerned with the treatments of the symptomology?
oh yeah, I mean, I think, sorry, when I said nobody's that poorly trained, I was specifically referring to physiatrists that are writing independent medical examinations
Oh, I see.
and having this problem. But I take your point that oftentimes in the medical records, you'll see that someone has followed up with their family physician and has developed what could be one explanation could be post-concussive symptoms, and on the basis of that, a diagnosis of concussion is made in the chart. That's frequently inaccurate. So I think what's often happening there is a couple things. One is that for them, they're dealing with what's in front of them, and they're saying, what's the harm in making a diagnosis of concussion? It's just going to tell this person to rest a little bit or something like that. That's the downside. And from their point of view, they're saying the downside of me missing a diagnosis of concussion might be meaningful. So I can see why there might be maybe a bit of a bias there to just write down a diagnosis. That, and then they may also just simply not be trained in understand. Like that's what I think is probably going on, is that the generalist out there is not actually aware of what the differential diagnosis ought to be that should be explored. So maybe I can spend a minute just talking about what that differential diagnosis should be.
Yeah.
So yeah, okay. So in the hyperacute setting, meaning like right after an impact occurs, it's like this. If there is no clear acute neurological dysfunction, meaning the person hasn't become stuporous, disoriented, meaning they're not able to say their name, not able to say the date, etc., or they haven't physically passed out, like actually passed out where they're not able to engage with the environment at all. Right? If those things haven't happened, then there probably is no concussion. What I'm trying to say is, in the absence of acute neurological symptomatology, there is no concussion. So sometimes people will have symptomatology that sounds like acute neurological symptomatology, like I saw stars, or like I became confused, or like I was scared or anxious, or I felt like I was in shock. You get lots of reporting like that. So the thing to keep in mind there is that the person has just been through an unexpected, potentially life-changing event. It's extremely normal in that situation to have an adrenaline response, like a fight or flight type of response. And in a fight or flight type of response, it's well understood that memory lapses can occur. It's well understood that people can see stars. It's well understood that there's changes in blood flow in various parts of the brain happening. So people can have what sound like traumatic acute neurological symptomatology, but really it's not that. Okay, so they're having this adrenaline response, or they're having an emotional reaction to an unexpected life event, and they're basically freaking out. They have an anxiety response or a panic response. And that can also present with things like, well, I don't remember it all that well. The other thing that can happen is if it is like if it was a bad accident where they thought they were going to get seriously injured, or they thought they saw somebody get seriously injured, or, they had thoughts that they might be dying or something like that. Like those are extraordinary circumstances where people often have exaggerated emotional responses that can look, to an undiscerning eye, they can look like an acute neurological dysfunction. So the key thing, I think, to figure out early on is, number one, when EMS, meaning the emergency medical responders, documented how that person was doing, Did they note any abnormality with disorientation, etc.? And then the other thing that I explore is, was the person able to engage in goal-oriented activities or not? So the ones that I typically look for are, were they able to drive away? Like we've all seen videos and stuff of, like, I don't know, NHLers or something getting a concussion and they can barely walk. These are high-level athletes that can barely walk, let alone drive a car. Right? So driving a car is a high-level cognitive exercise. So being able to do that suggests that there is no brain dysfunction. Exchanging information with another driver. Sometimes people will say things like, I was so concerned about the other driver, I had to go check on them, etc., etc. That whole process of being concerned about someone else, having the empathetic response and all that, and then being able to physically move the body in space to the other driver, have a conversation with language and attention and all that stuff with the other driver, those suggest a high degree of intact neurological function. So those are the things I explore to see, acutely, could there have been a concussion here or not? So then, when could there have been a concussion? Usually it's the EMS will have documented something like, this person's not able to count to 10. This person is not able to tell me their last name. This person doesn't know what year it is. And that may only last for, half an hour or something like that, but it's still a clear alteration in the person's sensorium or level of consciousness.
Yeah.
Yeah, so that's the acute thing. And then the chronic thing, there's a differential diagnosis for that. So we said the differential diagnosis for the acute stuff. The differential diagnosis for those chronic symptoms that are often interpreted as post-concussive symptoms, there's a few things. It's actually very similar, but basically emotional distress. So when people have ongoing symptoms, sometimes they become anxious or depressed, and there's a huge overlap between anxiety and depression symptoms and what are called post-concussion symptoms. The other thing is whiplash itself is associated with complaints of dizziness, anxiety, visual symptomatology, etc. So you don't really need to invoke a diagnosis of the central nervous system when a diagnosis of whiplash injury in itself encompasses those symptoms.
Right.
So that's another differential diagnosis. And then sometimes people develop chronic pain. And we know that when people develop chronic pain, they have subjective problems like distractibility, not being able to focus, etc., etc. And sometimes they also become sleep deprived. So all of that can just look like post-concussion symptoms. So all of that needs to be explored. And I try to explore that thoroughly so that, like you were saying earlier, like the early practitioners, what are they really caring about? Well, I don't think they're necessarily caring so much about finding the truth of it all and explaining the truth of it all to someone who might not know the medical stuff. Whereas that's how I see my role. And so that's what I take seriously at that time. But yeah, I think other people are just not necessarily having to take that seriously.
Yeah, absolutely. No, very good. And I was looking forward to having that exact discussion with you that we just did, because as I say, most of the folks that are listening into this, time and again, we're confronted with bundles of medical records, and it usually is several months after the fact that people start to they start to report, well, maybe I did hit my head. We start seeing these diagnoses of concussion. And what I really wanted to emphasize for all the listeners today was exactly what you just said, which is that there are other things that we have to look to, and you do need to focus on whether there was that acute neurological dysfunction.
So then, Dr. Acharya, what we're looking at is, can you describe in general terms, without getting into specifics of names or cases, exactly what your process is when conducting a physiatry evaluation, especially on the defense side?
Sure. And yeah, thanks for putting that little caveat for me there about not discussing a specific case. I know you guys mentioned a case at the beginning there, but I'm just not totally sure if what the college would say about me commenting on specific people that I've examined. So I'm just going to stay away from it just to be safe. But
we won't ask you for specifics, and we'll note that as well from any questions that we get from the audience. We're not getting into specifics today with you. We're just talking about generals, but generally.
Yeah, for sure.
What is your process?
There's a process.
Physiatry evaluation.
Yeah, totally. No, I just wanted to tell you I appreciate that. But yeah, so the process is like this. It's the first step is a history, meaning you understand what happened to that person. And within the history, there's a certain process, which I can go into in a second, but I'll just give you the big chunks first. So it's history. Then there's, based on that history, there's a targeted physical examination. So, okay, sorry, backing up. You have the history. From the history, you create a differential diagnosis. Then you hone in that differential diagnosis using the physical examination. Then you still usually have a differential diagnosis that's not fully established at the end of that. Then you go back and do things like get further investigations that are necessary in this sort of setting. That means looking back into the medical records. And so in looking in the medical records, there's a couple of things that I'm generally looking for. One is what's reported to me consistent with what I find in the medical records, or are there discrepancies there that need to be explained? And the explanations for those can be variable, but generally that's what I'm looking for in the medical records. The other part of that that's important is that a very common diagnosis that's made in people that have pain symptoms ongoing beyond the natural healing time is chronic pain syndrome. Now, it's important to note that the diagnosis of chronic pain syndrome is entirely based on subjective symptom reporting. It's basically the absence of objective findings, but reports of pain, right? So what I'm trying to say there is that when I make that diagnosis, it assumes that the symptom reporting is valid. And so if it's not valid, meaning if I'm looking back in the medical records and there's discrepancies in the symptom reporting, it's not valid, then my diagnosis is not valid. So I find that important to corroborate what's being said to me with the medical records there. The other thing in the medical records is to look for to establish an appropriate baseline. So that's actually pretty much the first part of my history is establishing an appropriate baseline. So event A occurred. What were things like just before event A? Because oftentimes you see that people have an accident and sort of everything gets blamed on that from then on, even stuff that was there before that.
Yes.
So like if a person's, I don't know, going to a massage therapist and the massage therapist is saying they've got pain in their neck and mid back and low back and arms and legs and head and hair and teeth and fingernails, prior to the accident, well, that is a different baseline than sometimes is what's reported. So I often, get a baseline history from people. And you often hear that people are generally healthy, and that's sometimes they truly are. But I usually try to get them to clearly say to me, so if I'm understanding you correctly, you were healthy with no ongoing symptoms at the time of the accident. And if they say that, and then that's not what I find in the medical records, then I have to question their validity of their symptom reporting. Okay, so so history, differential diagnosis, physical examination, differential diagnosis, medical records, differential diagnosis, and then after that you come to hopefully an actual diagnosis, or you stick with a differential diagnosis because there's multiple potential things and you have a plan for further investigations, etc., that need to be done to narrow that down further. So that's the typical process. Usually I'm thinking about things because I've gotten used to the types of questions I'm being asked. So usually it's like, what's the diagnosis? So I try to think about that in terms of what happened initially, like i.e. was there a concussion? Was there not a concussion? Was there a whiplash-associated disorder? If so, what grade? Was there some other acute musculoskeletal or neurological injury outside of whiplash-associated disorder that also occurred? And then I also try to come up with diagnosis in terms of what is happening now. So a common problem that I see in independent medical examinations is that people will list diagnoses that make sense acutely. Like you often see things like sprains, musculoligamentous sprain, strain, cervical, musculoligamentous sprain, strain, thoracic, and like whatever body part, body region you can think of is just listed like that. So that may be true acutely, but the natural history of musculoligamentous sprain, strain injury is to have resolution within several months. We're talking several years later now. So is that a diagnosis that we're really making now? And if so, the discrepancy between that diagnosis being present now and the natural history of that diagnosis has to be discussed. So what I'm trying to say is I make diagnoses for what happened acutely, and then I try to also make a set of diagnoses for what's actually occurring now that explains the symptoms. And that's typically the process. And then the rest of it comes from the diagnosis. So as long as that step is done properly, I think the rest of it just follows from that. Like the prognosis just depends on the diagnosis. The treatment depends on the on the diagnosis. And then one additional step that I typically take in the independent medical examination kind of setting versus my typical clinical practice is to be really clear about, like I'm usually asked about disability. So I think it might be useful actually for the crowd to hear some thoughts of how I approach disability in this setting. Would that be okay?
Disability and I guess whole person impairment ratings?
Yeah, whole person. Yeah, sure. Yeah. Okay, so yeah, there's a few words there. And in this, I would say that people are actually poorly trained, okay? In this next, so I actually make pains to train our residents that are coming through here. I basically talk to them they ask for it. I talk to them every year about this vocabulary these specific words that I'm going to go through. So I think you guys are, in the insurance and legal realms are probably actually much better than the clinicians in general about knowing what you mean when you talk about these words. Impairment, disability, restriction, limitation, and capacity, and risk comes in there too. So these words are poorly understood. Like we're asked as physicians to fill out forms all the time, right? And these forms will say, what are your patient's limitations? And the typical approach to that, I kid you not, is that the physician looks over to the patient and says, what are your limitations?
Yeah.
And then they write that down. So it becomes a scribing exercise. Like that does not take, there's no medical thinking occurring there. The way it's supposed to be done is that the physician figures out what the impairment is. So by the way, if you ask, like honestly, if you ask even physiatrists, what's the definition of impairment? They may have trouble defining what that is. But basically what it is any deviation from normal in a body system. So, so a person can be, for example, an impairment can be a broken bone, or an impairment can be a brain injury or diabetes, or pain can be an impairment of its own, right? So a deviation from normal. So based on the impairment, then the limitations follow from that. But what happens is people confuse self-reported limitations, which are actually better termed functional intolerances. And by the way, the reference for all of this is the second edition of the American Medical Association's Guides to Return to Work and Workability. It's all in there. The first 3 chapters are just very valuable if people are not familiar with this terminology, or if they're questioning how a physician's using this terminology. Okay, so sorry, back to the point there. Self-reported limitations are often better referred to actually as functional intolerances. Limitations that are purely based on the impairment are referred to as physiological capacity limitations. There's a big difference between those two, and there's a methodology for figuring out if something that a person reports is a functional intolerance or a physiological capacity limitation. But the basic underlying thing, which I've explained to judges, I don't know, a dozen times now, is that physiological capacity limitations have predictive value over time. Functional intolerances do not have predictive value over time. So let me give you an example. Okay, sorry, this is a bit crude, but it's just the easiest way to, it's just obvious. So, okay, physiological capacity limitation. Okay? Let's say a person has quadriplegia, so they can't move their arms, can't move their legs. They have complete spinal cord injury. And they're coming into the office, and they're sitting in a wheelchair, and I say, okay, I just need to see how you walk. They cannot walk. It doesn't matter if there is a briefcase at the other end of the room with $1 million in it, that I say, it's all yours if you just pick it up. It doesn't matter. So what I'm trying to say is reward associated with the activity doesn't matter in a physiological capacity limitation. It doesn't matter what their educational status is. It doesn't matter what their sociocultural status or beliefs are. None of that matters. It's strictly physiological. Their culture doesn't matter. Which country I'm assessing them in doesn't matter, et cetera, et cetera. Functional intolerances, on the other hand, do vary with all of those things. Okay, so it's a person saying, I don't know, let's say, I have pain in my back, and so I'm at work, and I can't lift 50 pounds. But the same person, when they're at home, can lift their 50-pound dog, right? The physiological, or their 50-pound grandkid, or whatever, right? Something that has value, like reward. They get reward from engaging in that activity, versus they perceive, I guess, that there's no reward associated with the work activity. So that is not physiological, obviously, right? The same musculoskeletal and neurological function is required to pick up any 50-pound load, whether it's one that has an emotional relevance to me or not. So that's basically how you figure that out. Now, the problem with functional intolerances is that they have no predictive value over time. So if I'm going to try to prognosticate someone's disability, which basically means giving functional prognosis over time, like what is this person's disability going to be over time, I cannot use a functional intolerance, because the person can overcome any functional intolerance with the appropriate reward. So it's not a physiological problem. Whereas if I have a physiological capacity limitation, like I'm talking about, let's say with that person with quadriplegia that we were talking about earlier, it doesn't matter what the reward is. If someone asks me, is this person going to walk today? No. Are they going to walk tomorrow? No. I can be very clear about it. Right? I don't have to wonder about the circumstances. I can be very clear about that. Okay, so so the two often get confused in independent medical examinations. And so what's often happening is the problem I described earlier, where the exercises that a person is scribing a person's perceived disability, rather than going through this exercise to come to an opinion with respect to medical disability. So just to be clear there, perceived disability is what the person says they can't do. Some of that may be medical, but some of it may not be, or all of it may not be. Then there's medical disability, which is strictly based on physiological capacity limitations. And then the other one is medical restrictions. So medical restrictions are a bit different than limitations. Restrictions are imposed upon a person by a physician. So an example would be, let's say a well-looking man comes into the office and says, "Doc, I'm a pilot, but I just had a seizure. I'd like to fly a plane. I can fly a plane. I can do all the movements associated with flying a plane. My coordination is good. I'm thinking straight. No side effects of my medication, whatever." Right? Now, but the doc says, "I'm so sorry. You have the capacity to fly a plane, but there's risk associated with you flying a plane to yourself and others. And that risk is quantifiable in some way. Like there's a X percentage chance that you'll have a seizure while flying a plane. And so that risk is, on the basis of that risk, we're going to impose a medical restriction on you." So medical restriction doesn't imply anything about capacity. The person may have the capacity, they may not have the capacity, but a medical restriction is imposed. And it's truly an imposition on someone's life because it necessarily reduces their quality of life. So the reason I'm sort of like passionate about this, probably more than the average person walking around, is that confusing perceived disability with medical disability actually does harm to the person. Because when a person's coming to me, if I tell them that they're disabled, then they're disabled. I'm the expert in that. I've told them they're disabled, and now they are disabled, and they will disengage from whatever activities I tell them to disengage in, or they will avoid whatever symptoms I've told them are worth avoiding. On the other hand, actually the correct approach when people have perceived disability but no medical disability, which by the way is really common in chronic pain syndrome, which is a really common diagnosis in this setting. In that setting, perceived disability is treatable via a process called hurt versus harm counseling, where we explain to them that we can validate their pain symptoms, like, yes, you're telling me you have pain, therefore you have pain, because I don't have any reason to believe that you're lying to me. So yes, you have pain, I validate that you have pain, but I do not validate your self-limiting behaviors related to your pain.
Right.
Because if I did do that, I would worsen your life. And I've taken an oath not to do that, so I won't do that. And that's sometimes a difficult conversation, but it's the only correct conversation.
Right.
That was a bit long, but yeah.
And we've got a couple questions I'm gonna ask you, Dr. J, that some folks have put in. But before we do, just since we're on that topic, the risk of course, of not engaging in the hurt versus harm. I'm sure there's others that I'm unaware of, but the one that comes to mind is somatic symptom disorder. That's the risk that you run? Is that somebody develops, it then becomes a psychological issue?
Well, yeah. So just in terms of terminology here, there are some terms that are basically used interchangeably. Okay, so it just depends on a person's training. So physiatrists will often use chronic pain syndrome. Rheumatologists will often use fibromyalgia. Excuse me. Psychiatrists will often use somatic symptom disorder. They're basically interchangeable. I was just double checking the American Medical Association Guides to the Evaluation of Permanent Impairment. In their little glossary section, they have a nice statement that basically says that. So if you ever need a reference for that, it says that chronic pain syndrome is basically an umbrella term for all these other terms.
Gotcha.
So now to use somatic symptom disorder specifically, that's listed in the DSM, which is the psychiatric manual for diagnosis. And really, to be able to use that, you should be a psychiatrist. So I typically don't use that terminology. I use the terminology chronic pain syndrome.
Right. Okay. Well, that's a great jumping off point then, because Katie Camp has asked, and you might have already partially addressed this, but I'll put the question to you and you can give her a quick response. Is chronic pain syndrome the same as or similar to a diagnosis of fibromyalgia with regards to subjectivity and validity? I guess you've kind of addressed that.
Yeah, let me go into it a little bit. So usually the diagnosis of, so you were asking me what's my process earlier. So part of the process is the physical examination. And on the physical examination, one of the things that we do is palpate, meaning touch the person's body, particularly touch the musculoskeletal structures to see what's tender. Tenderness basically means that they report pain when that part of their body is being pressed on. So another common issue that I see is that happens in a physical examination and a person reports tenderness in a particular area, and the physician jumps to a diagnosis and says, okay, tenderness in that area means musculotendinous, ligamentous, whatever, strain, sprain, injury in that area. That's a possibility that should be on the differential diagnosis, but other things ought to be considered in that differential diagnosis. So one of these days, if we get time, we can go through the whole why there should be a differential diagnosis for all that, but there should be a differential diagnosis for that. One of which is that it's not actually a problem at the spot that the person is being pushed on, but rather a spot higher up in the pathway where pain is being brought into perception. And so in fibromyalgia, people often present with widespread tenderness, sleep dysfunction, meaning non-restorative sleep, meaning they wake up in the morning even after getting a reasonable number of hours of sleep, not feeling refreshed, and emotional dysfunction, like depression and anxiety symptoms, that sort of triad. That's very similar to the presentation of a chronic pain syndrome. So they can probably be used interchangeably. If at some point there's clear evidence that differentiates some populations so that you can say, okay, this is the fibromyalgia population, this is the chronic pain syndrome population, we might get there, but I don't think anyone's made that distinction, and I'm not so sure that there is a distinction to be made at all. Right. Now, that might bring up the question that, people develop fibromyalgia in the absence of trauma. So how is trauma causatively linked to a chronic pain syndrome?
Right.
Well, I don't know. Okay, but so because it happened, the chronic pain syndrome, like fibromyalgia, may happen in the absence of trauma, right. Physical trauma, that is. There usually is some history of some kind of emotional trauma, like there's a high association with what are called adverse childhood events. What's called the ACE, there's a study called the ACE study, and there's a score called the ACE score, which stands for Adverse Childhood Events Score. All kinds of horrible things that happen to people that mess up their processor early in life. And so the inputs coming into that, the simplest way to think about it, inputs coming into that processor from the body are essentially misinterpreted. And in this case, they come out as pain symptomatology.
Right. Okay. Very good. Thank you so much for that. And thank you, Katie, for your question. Patty Sandiker asks, Dr. Acharya, actually, I'm sorry, I should have read the question first. She just wanted to mention that she's finding it very informative and wondered if there was a way to get a copy of the recording. And the answer to that, Heidi, is that yes, there will be a copy of the recording afterwards.
Absolutely.
I do have a question though, Dr. Acharya, since we're just coming off this conversation and particularizing the difference between fibromyalgia and chronic pain, concussions and whiplash. Something that we often see in our, especially from physiotherapists, right? When it's a motor vehicle collision and we're getting the treatment plans, one of the first things we all go to, of course, is the diagnoses. And it seems like every time that I'm looking at the diagnoses, I've got not only a diagnosis of a whiplash-associated disorder, but there's also diagnoses of sprains and strains. And I'm often left wondering, is it possible to have both of those things at once? What is the difference between a cervical strain and a whiplash-associated disorder 1 or 2? So maybe you could just speak a little bit to that.
Yeah, sure. Okay, so basically a whiplash-associated disorder implies the mechanism as some kind of flexion extension force going through the body. Okay, so it can apply to cervical, thoracic, lumbar, etc. But sprains, okay, just to get the terminology right, sprains refer to a load or an injury sustained because a load is applied to a tendon or ligament, okay, that overwhelms its structural integrity. Okay. So those can be minor, like you could just only see those changes microscopically, or you could see them macroscopically using like an ultrasound or an MRI, or it can completely tear through the structure. Those are basically the gradations of sprains. Sorry, I think I said tendon earlier. It's ligament. Okay, the sprains are for ligaments. Strains are for the muscle tendon unit. So when a muscle tendon unit is a force is applied, any type of force. It doesn't have to be necessarily a flexion extension, acceleration, deceleration type of force that you see in a motor vehicle accident. It can be a blunt trauma. It can be a crush injury, etc. It can be a person rolls their ankle, something like that. It can be a sports injury. It doesn't have to be Like whiplash implies the mechanism. Sprain strain is really just talking about the diagnosis at the level of the tissue. Okay, so a strain refers to muscle and tendon, sprain refers to ligament. And basically they're all forces applied to these structures that overwhelm their structural integrity.
Right. And then where does the whiplash associated sort of fit in with that?
Yeah. So if a person has sprain, strain type of injuries, with a flexion, extension, acceleration, deceleration type of mechanism, like you might see in a rear end or a T-bone injury or something like that, people often call that whiplash.
Right. Right. Okay.
And I guess the other thing is that whiplash-associated disorder is like a syndrome, meaning it's a collection of signs and symptoms. And so the sprain, strain is part of that. But then there's other things which we sort of touched on before, which is that people with these injuries often also complain of dizziness, lightheadedness, visual changes, imbalance, ringing in the ears, feeling panicky, palpitations. All these other symptoms can be encompassed into that. That would be sort of outside of the sprain, strain part of it.
Right. Right. Yeah, absolutely. And then a closely related question here, and I mean, you oftentimes offer opinions on other people's work, and the conclusions they've drawn. So I feel comfortable asking this question, but how much stock do you think can be placed on the diagnoses that are offered? And of course, I'm talking generally because different people could have different educational backgrounds. But generally speaking, how much weight should folks be placing on diagnoses that are offered by physical therapists, so massage therapists, physiotherapists, and chiropractors? To what extent can we take them, at face value, their diagnoses at face value, or is there, generally speaking, a reason to question those diagnoses?
Okay, in general, I would say it would be considered out of scope for anyone but a physician to make a diagnosis, make a diagnosis or diagnoses. So, coming to diagnostic opinions is in the realm of medical doctors only. There's some things I don't know about, like can an optometrist diagnose a retinal problem? I don't know for sure on that. But within the musculoskeletal and neurological realms, I'll sort of stick to the areas that I know.
Yeah.
Diagnosis is the purview of physicians only. Okay. So now, having said that, there are times when a physical therapist will make a diagnosis, and they're usually right. Like there's usually a whiplash-associated disorder, it fits with that. What they should rightly probably say is that the symptoms that are reported to me suggest a diagnosis of, but I'm not a physician, therefore diagnosis is out of my purview.
Right.
I see psychologists doing that correctly a lot, actually. I also see them making diagnoses, and I think the same thing there. Like I feel like a psychiatrist ought to make a diagnosis, and a psychologist can say something sounds like a diagnosis, but probably actually shouldn't make a diagnosis. Right. But again, it's the same kind of thing where it's like, they're probably right. If it's like but I wouldn't take it at face value. I would say, I can say they're probably right because I am actually making a diagnosis and it happens to be the same diagnosis.
Yeah, exactly.
But for someone that's not actually making a diagnosis, I would not take a non-physician's diagnosis at face value. And then even another layer on top of that is that it depends on the type of physician in terms of what's the reliability of various physicians making various diagnoses.
Yeah.
So a family doctor is different than a physiatrist, is different than an orthopedic surgeon and a neurologist and all that stuff. Mm-hmm. And even within that, so if you have two physiatrists making diagnoses, it's like, what kind of patient population do they see? How are they coming to their diagnosis? Do they actually follow the typical medical methodology?
Right.
So so I guess my overall answer to that question is, if the diagnosis from a physical therapist or non-medical person is questionable, it should be questioned.
Yeah.
If a diagnosis from a physician is questionable, it should be questioned.
Very good. Okay. I did have another question I wanted to ask you. I'm kind of hitting the highlights of things that we see every day. I know we're kind of a little bit all over the place, but I'm just trying to cover some of the bases, address some of the issues that we're seeing most commonly. But before I ask that, we do have a question. Heidi does have a question for you, and that is, can a person sustain a concussion without hitting their head? Can whiplash cause a concussion?
Yes. So a person can, so there's two parts to that. A person can sustain a concussion, yes, without hitting their head, absolutely. So a sudden acceleration, deceleration of the head, or even of the body, which transmits forces to the head, can transmit enough force to disrupt the brain structurally at the level of the neurons or the other cells in the brain, which are called glia. And that can certainly cause acute neurological dysfunction, i.e. a concussion. In fact, you can have, so concussion and mild traumatic brain injury are basically synonymous. They're just used in different settings, like concussions typically sports, and mild traumatic brain injury is other things outside of sports, but they're basically the same thing. So I use them interchangeably. But at the more severe end of brain injury, you can actually have an extremely severe brain injury without impact to the head. So such sudden forces coming through the head through flexion and extension and acceleration, deceleration movements can result in some of the most severe traumatic brain injuries. Now, those are people that are comatose at the scene. Right? Those are people that do not return to living on their own generally. Those are people that require extensive rehabilitation and major modifications to their environment. They can't make their own decisions. Like it's bad when those sort of things happen. So certainly, to answer the question, yes, you can have a brain injury without direct trauma to the head. Now, you can also have direct trauma to the head without a concussion. So there's a difference between a head injury, which means a head injury means that the tissues of the face and head and neck or the skull have been impacted. That doesn't necessarily imply that there was a neurological injury sustained. People have that all the time. You get a goose egg from, I don't know, standing up too quickly, getting into the car or whatever. Yeah. So you've had a head injury, but not a brain injury.
Right. Okay, and then you know what? That question that Heidi asked, and your answer actually ties really well to what I wanted to bring up with you. Okay. Again, in thinking about the things that the folks that are listening and that Nabil and I and our team encounter all of the time, and on the topic of traumatic brain injuries, you and I, once upon a time, you educated me on the significance of Montreal cognitive assessments. And
okay.
You wouldn't have any reason to remember it in particular, but not having a medical background, I didn't know what significance to attach to them, and I don't know if any of the folks listening are with me on this, but typically when I would receive a MOCA test and see that somebody didn't score well, I would think, oh my goodness, right? And just like that, our damages assessment is starting to climb because this person, they failed the MOCA test, and that means that they must have some type of a neurological disorder. But you educated me, you taught me that isn't so, that it's a screening test. And so I wondered if maybe you could speak a little bit about the MOCA. We all see them all of the time. I'm sure that there's some uncertainty about the significance of those tests, and I wondered if maybe you could speak to that.
Yeah, sure. Okay, so the utility of the MOCA is a useful test in some settings. Like basically, it's a bedside, quick cognitive screen. So I think the word that you use there, that is a screening test, that phrase is correct. So in medicine, screening tests are used to put a diagnosis onto the differential diagnosis. They're not used to make the diagnosis as such. So if somebody has a low score on a MOCA, there could be multiple explanations for that. Again, by the way, including some of those other things we talked about earlier, like they're distractible because of their pain, or they have a brain injury, or they have an emotional dysfunction, or they're really tired. There's lots of explanations for a MOCA to be abnormal. But now, so if I do a MOCA on someone and their score is low, that triggers me to then say, if I'm actually thinking that the person has a cognitive, an organic brain dysfunction, meaning they've had a traumatic brain injury and haven't recovered from that, and therefore their cognitive processing and stuff is abnormal, then the right next step is to ask for formal neuropsychological testing. So informal neuropsychological testing, I mean, I'm sure a neuropsychologist can tell you more details about exactly what this is, but basically there's all these intrinsic reliability and validity tests built in. And they can differentiate certain substructures and anatomical areas of the brain. So for example, like language processing, memory processing of various different types of memory, visual processing, verbal process, et cetera, information processing speed. There's so many different things that they validly test for in a comprehensive battery. And so, yeah, if someone's MOCA score is low, the first thing I look at is, do I actually think this person has a cognitive problem? Or is it actually more likely that the low MOCA is on the basis of one of these other differential diagnosis things? Now, if I actually think that there's a cognitive issue going on, And if there's some utility in figuring out exactly what their strengths and weaknesses are and where they score on these things and all that, for reasons like planning employment and prognosticating and stuff like that. Then the next step is neuropsychological testing.
Right. Right.
And it's through neuropsychological testing that formal diagnoses can be made.
Right. Yeah, very good. Okay. And that was that was the second most important thing on my list of things to have you confirm for everybody today was at the very least that MOCA is simply an indicator that further neurological testing is warranted, right? That's
Yeah.
the bottom line.
So then, Dr. Acharya, two more questions for you before we wrap up. First would be, what specific information and evidence are essential for a physiatry evaluation, and where can we get that? Like, how can we help you get
Oh,
that?
okay. Well, so having the medical records from prior to the incident, whatever it is really helpful to establish that baseline and corroborate the history and see if there's valid symptom reporting or not. So I
And,
think,
and how far back, Dr. Acharya? How many years prior to the incident?
okay, good question. So honestly, whatever you have is good. And the reason I'm saying that is because there are some diagnoses that may be diagnosed, so let's say 10 years prior, and are expected to worsen over time. And so what I try to do is say, okay, so but for the accident, let's say, what would this person's trajectory have been medically, right? And so to do that, I may have to go back that far and find out what established diagnoses there are, and see what the natural history of those is. So that's one. The other reason to go back as far as you can is to see, like, it's fairly common for people to have sporadic musculoskeletal complaints in their life. Like, it's very common. I think it's like more people have it than don't. For example, a history of intermittent low back pain. Okay, so an episode of low back pain. Now, if the medical records make it look like it's actually recurring and increasing in frequency over time, that may present one pattern for the future, because there's no reason to think that's really going to change. It'll probably just continue and accelerate in that direction. On the other hand, if the person really has, like, one episode of low back pain after lifting something and it's gone away, there's nothing on 5 years either end of that or something like that, you'd think, okay, maybe that is just one incident and it doesn't actually change their prognosis, and they wouldn't be expected to have any more low back pain going into the future necessarily. So I think whatever you have is generally good. If you can go back at least 2 years, that's helpful. And the reason I say that is because we're often dealing with musculoskeletal and neurological differential diagnoses. And typically, the literature would say that if those kind of complaints are present for more than 2 years, they're likely to persist indefinitely. So if you can go 2 years, it's great, but everything is helpful there.
Yeah.
And then acutely, it's very useful to have the ambulance records, if there are any, or the very first medical assessment, or the police reporting. So, when the person fills out a police report, especially if they fill it out like immediately, they go straight from the place to the station or whatever to fill it out. That's helpful because you're basically assessing their language function, their attention, their recall, all that stuff by looking at how they wrote in that acute phase. So those things are helpful. And then it is helpful to see their treatment records to know if they've had appropriate treatment or not. I scour through those trying to see if people have actually had appropriate treatment for what is, like, again, the most common diagnosis is going to be chronic pain syndrome here, right? So oftentimes what I find is people have had appropriate treatment for a whiplash-associated disorder, but have not actually had appropriate treatment for a chronic pain syndrome because the pathophysiology of those is different. And if one day when we have time, we can go into that. But we were touching on it earlier, that the treatment for chronic pain syndrome, one of the main components of the treatment is hurt versus harm counseling. And so I'm looking for evidence of that having happened, that conversation having happened. And I'm sad to say that I often don't find that it's happened. Yeah. So sorry. So the treatment stuff is useful. Other specialist reports are useful. Anytime the examinee has had to document what their symptoms are, is useful. Again, for that validity piece. Sometimes you have delayed onset of symptoms, so having the first time symptoms are noted in the medical records is very useful.
Yeah.
Okay. I don't believe there are any further questions.
No, yeah, I think we've made good use of our time, Dr. Acharya. It's been a full hour, and there aren't any other questions in the chat.
Well, thank you very much, Dr. Acharya, for joining us today. We are going to have another session October 28th with Dr. Joanne Mundine, psychiatrist, focusing on defending personal injury claims from a psychiatric perspective. Like we mentioned earlier, the session is being recorded for those that missed it. That will be circulated shortly. Again, Dr. Acharya, from both of us here at Brownlee, thank you so much for joining us.
Yeah, thanks for having me, guys.
Thank you.
Thank you so much.
And thank you to the audience for joining us too. Appreciate your lunch hour.
Yeah, thank you, everybody.